hear the word Omicron so much anymore. You'll hear words like BQ and XBB. And what we're finding is maybe the virulence of these, meaning how sick people get, might not be nearly the same as, say, Omicron, but the transmissibility and the infectiousness of these is becoming more and more as these continue to mutate. So we're finding more people that are likely getting COVID, but thank God are also getting less sick at the same time. In terms of how COVID then impacts patients more with chronic medical conditions, this is also boiled down to more to DuPage County. This is from the Illinois State Department in terms of the health department data. And this really looks at what were the percent of people that had COVID and what were their comorbid chronic medical conditions. And as you can see on the bottom right, obesity really has continued to be the biggest #1 risk factor. And then you see diabetes, heart disease, emphysema, COPD, chronic kidney disease. I could not give you real great data on cancer specifically. These have been usually the buckets that people have looked at as risk factors. We do know that obviously other things like immunosuppression, current cancer treatment, or just an underlying malignancy, age, and a whole other host of medical conditions really do impact COVID and getting COVID and how sick you get. But these are some of the historic kind of markers that have always kind of been looked at. You know, if we look at then in terms of when we're thinking about COVID, and there's always obviously a lot of talk about immunizations and where things were and where things are at currently and how we think about COVID in terms of preventing mortality and hospitalization and transmission when it comes to immunizations. And of course, what that means now with the newer bivalent boosters, I thought I'd probably talk a little bit about that. So this slide shows, and this is also from the CDC, the next series of slides. This is looking at immunization status, COVID mortality, and age groups. And I took basically the 65 to 79 and then the 80 plus age groups. And that bigger, taller curve with the Omicron spike in January 2022, that is unvaccinated individuals over the age of 80. And the curve underneath it, from the purple to more of the pink color, is unvaccinated individuals ages 65 to 79. And then the lower curves underneath are the solid purple, are patients that have been vaccinated but have not had a booster over the age of 80. And then underneath that are vaccinated and no updated booster, 65 to 79. So you can see, typically if you're a little younger, the mortality rate is lower. And if you've not been vaccinated, mortality rate is also kind of higher as well. And so on the bottom of the slide, it kind of distills it down to patients age 5 and older with the updated bivalent booster having an 18.6 times lower risk of dying from COVID. And that's from data from October 22. And then a 3 times lower risk of testing, positive for COVID as well. So, oftentimes people say, well, if you get the vaccine, you can still get COVID. And that is true. And flu vaccine is very similar that way. But I will say there is a window after the vaccine that we're not clear on exactly how long that is, but it could be as long as 8-10 weeks, where you definitely do have a lower risk of getting COVID immediately after you've been vaccinated. That does then tend to go away. And then what I will tell people, if you do get COVID and you've been vaccinated, as this slide shows, your risk of getting sick is just greatly diminished. And the conversation is very similar to the flu vaccine, which is the same way. A lot of people will say, well, I got the flu vaccine, but I got the flu. And certainly that can happen like a COVID vaccine. However, the benefit still is on how sick you get. We know from a hospitalization standpoint, if you've been immunized for flu or COVID, less chance of getting sick. And we also know, even with the flu, which is interesting, that with the flu vaccine, you'll get less sick. And not only does your hospitalization risk go down, but because you get less sick if you had a flu shot and then got the flu, you even have a lower risk of being admitted to the hospital for heart failure or stroke, and strictly because less strain is putting on your body when you're sick with something like the flu. And I think, with COVID, we see kind of some of that same thing as well. If we looked at from mortality impact to the hospitalization rate, this is kind of showing the same thing. That green tall spike around Omicron shows our unvaccinated population, and the blue showing different levels of whether you've had the primary series, so 3 shots plus a booster, or did you have 2 boosters, and then the dot way down low right, the blue dot is showing if someone's been fully vaccinated and has also had the bivalent. So you can see there's that reduction in the frequency of being hospitalized if you've been fully vaccinated versus not vaccinated at all. So we know that there's that benefit, and this kind of sums that up a little bit more in terms of the numbers. And essentially, if you average these out, if you've had the bivalent booster and you've been fully vaccinated, your versus unvaccinated person would have a 16 higher rate of being hospitalized, and then also 2.7 times higher if you're vaccinated but didn't have your updated booster vaccine. So again, just driving home what we just were talking about, how the COVID vaccines, and the more you've been kind of had the latest booster and whatnot, that your hospitalization rate is lower. Now, granted, it looks like that primary series and early on probably has a bigger impact, and further ones, the impact might not be as pronounced. And we're beginning to learn a little bit more about that. And that primary series really probably is where the rubber kind of meets the road. But around that time back then as well, COVID was more virulent and more people were being hospitalized. If we then get more granular and just look at DuPage County and look at where are our vaccinations rate for all of us that live in this area, the bivalent booster rate in the United States is roughly 14, 15% in that range. DuPage County, we're doing a little bit better than that. There's that one row that says percent of population greater than 5 years of age. And to the far right, if you've had the bivalent booster, almost 25%, a lot better than the US rate. And you could see as the population's older, so the very last row, percent of population greater than 65 in DuPage County that's had a booster, 57%. That's actually higher than what I thought that was going to be, and that probably speaks to somewhat of access and being able to get somewhere to get a vaccine. So really that speaks well of in terms of people being able to get the vaccine and then really getting themselves as protected as they really possibly can. But I thought that was really good to see just how we're doing in DuPage County as a whole. If we look at treatments, as I was mentioning earlier, in terms of how the viral mutation impacts treatments, here's 2 examples. I think we've all heard the term monoclonal antibodies. So that was something we used in early COVID, where if you got sick with COVID and you contacted your doctor's office, sometimes you'd be sent for monoclonal antibodies. And the way a monoclonal antibody works is if the spike protein on the COVID virus has a specific shape, the monoclonal antibody basically neutralizes it by attaching to it. So it's very much a lock and key phenomenon. And Evusheld is a monoclonal antibody treatment that for a lot of our immunosuppressed patients, cancer patients, patients with rheumatologic disease and are on these really strong immunocompromising based medicines, maybe our transplant patients as well that are immunocompromised, HIV patients, patients with immunodeficiencies that they're born with, patients on high doses of steroids and chemotherapy. This whole group of patients in the past, and maybe some of you have had Evusheld. It is a preventative medicine that you would get as a mixture of 2 monoclonal antibodies, and you would get it every 6 months as a way to prevent you from getting COVID. You'd have to dose it at least 2 weeks out from a vaccine, but then as the virus, as I was talking about, was beginning to mutate more, now our current resistance rate that I have down there is 91% as of January 2023, which now renders Evusheld, which is monoclonal antibodies, and our monoclonal antibody therapy has rendered it essentially ineffective. There is research going on to how do we make these monoclonal antibodies that aren't subject just to the rapid nature of viral mutation and then resistance, and what can we do better from that perspective. So more to come there, but that's how this viral mutation and genomics we mentioned, how that really influences even current treatments that we have available. As far as other treatments, I'm sure most people have heard of Paxlovid. It reduces risk hospitalization by 89% in high-risk individuals, decreases hospitalization rate or death if someone was vaccinated over the age of 50 by 44%. And we really see the biggest reduction in the highest risk patients. So patients over 65, not vaccinated, multiple risk factors like immunosuppression, obesity, and some of those things we've talked about, that's where you really get your biggest bang for buck on using Paxlovid. It has to be used within 5 days of symptoms. It can reduce the risk potentially of long COVID. It's a 5-day treatment. It does have a fair amount of drug interactions. And the one that's really bothersome, unfortunately, is patients that are on certain blood thinners, especially things like Eliquis and Xarelto, because you cannot combine Paxlovid with that. Now, if the patient can come off of some of those medicines, like cholesterol medicines, and go on Paxlovid, great. But if they can't, or if there's a kidney disease issue, we might have to go to molnupiravir. And so that's a very similar medicine to Paxlovid in terms of how it works and decreases viral reproduction of the virus. It's not quite as effective, about 30% effective at reducing hospitalization rate, but it is something we'll use as step 2 if a patient cannot go on Paxlovid. Remdesivir, Veklury, can be used in the hospital, but can be used in the outpatient setting. It's given IV for 3 days once someone tests positive and they're higher risk. Has to be used within 7 days of symptoms, 87% reduction hospitalization rate. It's just really hard, though, to find an infusion center or a place for patients to go to get this done. It potentially might be a little more reasonable, potentially with less COVID cases, as opposed to back with Omicron. But in the past, this has been a little bit harder to figure out. Current treatments for inpatient for Paxlovid, we aren't going to start it in the hospital, but we'll use it to complete therapy if it was started as an outpatient. Remdesivir, as I mentioned, that can be used. It reduces hospitalization from 15 to 12 days. Good, not great. More data to come. We use steroids in the hospital for patients that really start having low oxygen levels. And for patients that are really doing poor, end up on a ventilator, we do have some what are called for short BARC and TOC, monoclonal type antibodies and interleukin therapies that can be used for really severe disease, but that's more in our ICU setting. As far as cancer and COVID, we know our higher risk group are the patients with blood cancer, so leukemia, lymphoma, myelodysplastic syndrome, myeloma. And then the second group is our solid tumor, so our patients with breast cancer, lung cancer. And then lowest risk group within the cancer category is patients with a prior history of cancer. Obviously, the further out someone's been from their cancer and their treatment, the lower the risk. If someone's being transplanted or getting chemo, you want to wait on vaccination for 3 months. You do want to do a booster after they've done the first series of 3 shots. And then for patients that have had to be transplanted or have had T-cell therapy or maybe medication like Rituxan, that can wipe out your body's ability to remember the vaccine. So those patients would have to be revaccinated. And if we've got a cancer patient that gets ill, their physician would want to know right away to potentially get them on a medication like Paxlovid, immediately. How about if you test positive and you're immunocompromised because you're getting, say, chemotherapy? What does that mean for isolation? It is a little bit different because typically non-immunocompromised patients, you would isolate for 5 days and then mask for 5 more, and you can leave isolation. So it's 10 days, 5 days of the isolation component. However, for patients moderately to severely immunocompromised, the CDC would recommend a 20-day isolation period because you can shed virus and remain infectious for a lot longer. And then they also recommend doing testing, as it says in that second bullet, 2 consecutive COVID specimens more than 24 hours apart. And once that's been done, that would really then know that someone could come out of isolation. So I mention that because it is a little bit different than kind of for, again, our non-immunocompromised patients. As far as prevention, I think as we've kind of showed on the prior slides, getting vaccinated and staying up to date on boosters. I will say we don't know yet, since a lot of people got their bivalent booster in September, October, there isn't any updated information to say to get another bivalent booster as of yet. I think the CDC will probably give us some guidelines, recommendations on that in the next month or 2 to come, I hope, because we'll be coming up for some patients on about the 6-month mark come, March sometime. So I'm hoping we'll have some more recommendations that way. Be sure, if you're in a setting where you're indoors or around a lot of other people, if someone wants to be really safe, to wear the best mask they have, especially, like an N95, spacing, crowds, obviously hand washing, being good about, the coughing and sneezing and covering and disinfecting. And, again, if there's ever any cause for worry, getting tested, and if you test positive, to reach out to your physician and see if you're a candidate for something like Paxlovid. As far as future state, I think the virulence we've seen has gone down over time, which has been, a blessing, and hopefully we'll continue to see that. That is typically what we see with viruses. They become less lethal and more infectious. We're hoping it becomes more seasonal, like the flu. We've not seen that yet. So we're hoping that that's what's going to be future state. therapeutics, getting those monoclonal antibodies and Evusheld type medicines that can really neutralize that spike protein. They're doing a lot of research on finding areas of the virus that doesn't mutate as rapidly. What they found so far is binding that site doesn't have quite the same benefit in terms of the protective and the treatment aspect, so more to come. And there are a drug or two like Paxlovid in the pipeline that are being looked at in terms of how they would limit viral replication and do some of the same things that Paxlovid does. So a couple of those things that are on the horizon as well. So with that, I think, we've got a couple of minutes here for questions. So I see the chat right now. Can I get my slides up? But if you can let me